So, topic objectives is history and clinical examination, etiology, diagnosis, and the conservative treatments. We are starting from the introduction. Human bladder is a smooth muscle organ under voluntary control from the cerebral cortex. Normal bladder function require coordination between the afferent and efferent component and both somatic and autonomic nervous system. But many levels of nervous system are involved in regulation of fighting function. Therefore, neurologic disease can cause changes in the bladder function. Normal adult bladder is able to descend gradually to a capacity of 400 to 500 without appreciable increase in intravesical pressure. When the sensation of fullness is transmitted to the sacral core motor of cortex, cause reflexes are powerful and sustained uterusal contraction and urination. If voluntary control is lacking, like in infants. So this is the pattern of these sympathetic and parasympathetic, which work opposite to each other. The sympathetic contract the internal sphincter, while the parasympathetic relax the internal sphincter. Epidental relaxes the external sphincter. Parasympathetic works on the contraction of the detrusor muscle.
Wait for it. Regarding the nerve supply, we divide it into two major categories. One is autonomic, and the second one is the somatic. The autonomic is again divided into two further categories, which we call it the sympathetic and the parasympathetic. Can anyone tell what is the sympathetic and what is the parasympathetic bladder nerve supply or the root values?
Parasympathetic is SPF.
Okay.
Sympathetic coming from the
Dr. Agha,
axis.
you rightly said the parasympathetic is S2, S3, S4. What about the sympathetic nerve supply? It's basically the triangle number, which is T11, T12, annual, L2. So what is the function of the autonomic nervous systems? What is the function of the sympathetic?
Sympathetic system allows the bladder to put the urine.
The function of the sympathetic and parasympathetic is regarding the sympathetic activities. It will supply the detrusor muscles along with the internal sphincters. So internal sphincters contracted and the detrusor muscle relaxes. That is the sympathetic activity function. Regarding the parasympathetic, it's vice versa. The detrusor muscle contraction and the internal sphincter relaxes with it. What about the somatic? And what is the root value of the somatic?
And its function control the or stop the
And at which point it supplies to?
And it supplies to the sphincters, internal sphincters.
No, it's the external sphincter of that.
Sorry, external sphincters.
Okay.
If nerves harmed or any illness occur, the muscles will not coordinate and may not be able to tighten or relax at the right time. Several muscles and nerves must work together for bladder to hold urine and to empty the bladder. So the individual with the neurogenic urinary tract dysfunction is multiple sclerosis, Parkinson's disease, spina bifida, spinal cord injury, stroke, and major pelvic surgery, the diabetes and other endocrine diseases which lead the common complication of the urinary insufficiency, incontinence, and UTI. Bladder dysfunction also affect the social life of the patient. The neurogenic bladder is when bladder control is affected due to the brain, spinal cord, and nerve complications. Three areas of the central nervous system control the bladder function, which is cerebral cortex, pontine maturation center, and sacral maturation center.
Do you heard about the upper motor neuron lesions or the lower motor neuron lesions? Can anyone tell about the upper motor neuron lesions? A rough idea regarding the upper motor neuron you learn in your first year anatomy, neuroanatomy. So regarding the upper motor neuron lesions and the lower motor neuron lesions, the simple rule is at the level of the sacral S1, S2, S3, S4, from this to higher centers, brain, the spinal cord, up to that level, we call it an upper motor neuron lesions. From S2, S3, and S4 and below, we call it a lower motor neuron lesion. So my next question is, what are the effects if a patient presented to you in upper motor neuron lesions or a patient presented in the lower motor neuron lesions in your clinic? What are the symptoms? Dr. Srichand, what's your comment regarding the upper motor neuron and the lower neuron lesions? Sign and symptoms.
Upper motor neuron lesions to spastic paralysis, whereas lower motor neuron results in flaccid paralysis. Similarly, upper motor lesion will affect the group of muscles, and the changes are atrophy, which is very less. In case of lower motor neuron,
No. Regarding the upper motor neuron lesions, what are the presentation or the patients with what features or which complaints the patient comes to you? Don't go jump directly to the lower motor neuron lesion. First, the patients came with the presentations or the complaint of Vikalpa.
So patient may present with the atonic bladder, the patient may present with the urinary retention.
You talk about the upper motor neuron or lower motor neuron?
Upper motor neuron. Upper motor.
Upper motor, okay. Dr. Naman, regarding the upper motor neuron lesions, what are the clinical presentations present?
The patient with a complaint of hyperreflexia, spastic atrophy, increased frequency. He tries to void, but he's not able to void due to the completely multiple. And another thing, there will be the increased anal tone and increased sphincter contraction. So both symptoms will be there. He will be voiding in more frequency, but he will not be able to empty his bladder and bowel.
No. Regarding the upper motor neuron lesions, the patients presented with frequency in urgencies and may be presented with the stress incontinence. Regarding the lower motor neuron lesions, the patients presented with prolonged voiding along with the history of retentions along with overflow incontinence. Dr. Sadia.
I think you did a very excellent job. She presented it well that, as Noman was saying, that it could be frequency, but that will again depend where the lesion is coming from. And as you also mentioned, there could be incontinence, again, from all these three areas where the lesion is in the cerebral cortex or the pontine center and sacral maturation center. As we all know, cerebral is the godfather of the entire system. So it's controlling everything else. So once the inhibition goes from there, then it's going to be free flow. Coming down to pontine, almost something similar, but with sacral, it would be like patient might be aware of his symptoms. So from neurological aspect, then it would be more of, I guess, I think that more of a frequency that will be more prominent. Does anyone else wants to add?
What is the function of the pontine micturating center?
The pontine micturition center, it is basically the continent mechanism of the body. So when the bladder is filled and there are stretch receptors over the retrosal muscle and they got activated, they send the signal from the spinal cord to the cerebral cortex, and there is the inhibitory signals sent downwards toward the bladder to stop the micturition. That is the normal continent mechanism. So continence and voiding, it is controlled by the center. So it inhibits the contraction of detrusor muscle. So
Basically, coordinations and it gives the signals to the sacral spinal cord so that the precursor muscles contracted. In the same times, the pontine micturating center sends inhibitory signals to the thracal lumbar areas. That's the sympathetic activity. To stop that sequence so that there are better voids. That is the whole coordination of all those activities.
It is not only the coordination center, but it is also the facilitatory center. And this is not one center. There are two centers within the pons. One is the median pontine nuclei, and the other one is the lateral pontine nuclei. The median pontine nuclei, it's a group of nuclei which governs the micturation, that is evacuation. So M starts from medial, M stands for micturation. The other one, the lateral one, is more concerned with the storage. So it inhibits sort of micturation. So it's not a facilitatory kind of center, but it acts both ways. But there are two types of nuclei, two groups of nuclei, median and lateral. Sadia, ठीक है?
The neurologic bladder can classified according to different types of condition involving the tracer and sphincter activity. The tracer hyperflexia, which leads to involuntary contraction, leads to the sphincter dysfunction, reflex incontinence, and residual urine. And the areflexia of both the detrusor and sphincter muscle is due to mostly sacral injury and leads to the stress incontinence and residual volume urine. The areflexia of the detrusor muscle and the hyperreflexia of the sphincter leads to urine retention and overflow incontinence. And the areflexia of the sphincter and hyperreflexia of the detrusor muscle leads to the reflex incontinence. Here are other classification which is divided by the injury of the sacral, suprasacral, sacral, and infrasacral segments. In a suprasacral neurogenic bladder injury, the mostly from the brainstem and sacral center, which lead to disinhibited sacral reflexes and overactivity of the detrusor, overactivity of external and internal sphincter, impaired coordination of these muscles occur. In sacral neurogenic bladder is due to the occur in the injury of the sacral spinal cord, and the infrasacral neurogenic bladder occur due to the injury to the chorda equina. Both the sacral and infrasacral are the lower motor neurons. So, this diagram shows the sacral and spinal and infrasacral lesions, in which on a urodynamic in sacral and in spinal, the detrusor are overactivity, while infrasacral lesion there is the hypocontractile or acontractile detrusors. On ultrasound in spinal, there is post-viral residual urine volume usually raised, and same is in infrasacral lesions. So, patient history. History taking should be include the present and past symptoms, writing diaries is a first assessment, and non-traumatic neurological patient with a detailed history may be started in childhood or adolescence, History may be consist of urine storage and voiding symptoms. So the mostly symptoms you are asking about the onset of symptoms, relief after dividing, bladder sensation, initiation of micturition, stranding, intermittency, past history of catheterization, CSC, frequency, voided volume, incontinence, and urge episodes. We have also asked the bowel diary, a bowel history, which is very important in neurological patients, about the frequency of stool passing, fecal soiling, desire to defecate, defecation pattern, and rectal sensation. Is the Bristol stool charting, which is divided into 7 types. Type 1 or type 2 is mostly constipated, and 3, 4, 5 is normal. 6 and 7 is divided as mentioned as diarrhea. This is our institute bowel diary pictures, and this is the diary के पखाना किस वक्त हुआ, पखाने के किस्म, पखाना कब महसूस हुआ. So sexual function is also important in neurogenic bladder, which may inquire about the sensation in genital area, lack of erection, orgasm, ejaculation, and dyspareunia in females. Neurological histories asking about the acquired or congenital past history or mental status, somatic and sensory symptoms, hand function, mobility, and specificity of the autonomic dysreflexia. Past history of the heredity of familial risk factor, age of menarche, ops history, diabetes, other endocrinological diseases, neurological, any accident or surgery involving the CNS, spine, and pelvis. The current drug history and personal history of the lifestyle, sexual, bowel function, and quality of the life. The physical examination is very important in neurogenic bladder and should be described completely as possible.
How this diabetes affects bladder?
So, sir, diabetes के साथ probably neuropathy के साथ connect हो सकता है और autonomic function के साथ.
Because we see patients, diabetic patients with lower urinary tract symptoms. And when we perform urodynamics in these cases, we mostly get underactive. And mainly females are involved. We use females more than males, female diabetics. And usually when we perform that urodynamics, these bladders are underactive. And then they cannot help you. How this diabetes affect bladder.
So, if
If neuropathy.
so, most likely because when patients come to us, most of the time they're mostly talking about their lower limb symptoms, like have difficulty in walking or sensory symptoms. Less frequently, they've consulted us for urinary related symptoms, and they've not mentioned to us that they have urine related issues. But as you mentioned that they have, so I'm linking the two to the fact that it could be the peripheral neuropathy which is affecting their symptoms. Now, when you're suspecting that, could there be that they might be having ischemic strokes? That could be another thing, but then they should have bigger symptoms when you examine them. Then they should have hemiparesis or hemiplegia, but I guess you're not seeing those.
So we are not seeing.
Okay, can I ask a question at this point, or you mentioned a menarche history. How do we coordinate? How important is that when you're taking a menarche history? How do we correlate it?
It's basically part of the examination. Specifically, those patients who had history of urinary input or he has a routine history and the examination of the part of the key examination and the history.
I think the question is how does menarche affect your assessment of neurological deficit?
It's not related, but it's a part of the student.
It is related. It is related. It because a late menarche, for instance, relates to low estrogen levels in the earlier life. A low estrogen level leads to something which is like a senile urethritis and senile vaginitis, which acts like an obstruction to bladder outflow. So, in a wider sense, it affects the hormonal milieu, and it affects the normal mucosal integrity. So it affects in that way. So earlier your question was about the bladder dysfunction in diabetics. But to my understanding, it's always not the case with the peripheral nerves, which are the somatic nerves. It is also the case of autonomic neuropathy. Now, the autonomic neuropathy with diabetes and a non-compliant diabetic, perhaps, it affects both ways, gastropathy as well as cystopathy, and both the things are related to autonomic nervous system. So it affects the same way. Saltatory conduction delays the kind of sensation that goes up and down.
That's a learning point here that if
Yeah.
somebody has a gastroparesis secondary to diabetes, then we should ask them about their urinary symptoms too.
Yeah.
They might be coming together at times.
Yeah, because if, for instance, you happen to interview somebody who is a diabetic, a badly compliant diabetic, he or she will tell you that most often they are constipated. Maybe they are constipated once, and after some time they become diarrheal,
Right.
and they don't know what happens. The same goes with that's autonomic nervous system. The same is they feel dyspepsia, they feel indigestion, they feel a lot of vomiting and things like that. So that happens because maybe of DKA, which somewhere sets in, but it also relates to
Uncontrolled diabetes.
Yeah.
Thank you.
In physical examination, we also ask the reflexes and sensations of multiple genital area testes, like the anal sphincter, pelvic floor muscles examination, and motor level of spinal cord injury and extremity stone. This is your recommendation about the history taking, about general history present and past, about the symptoms is strong, and mentioning of the urinary ball, sexual and urological history is strong, and the possibility of alarm sign, example, pain, infection, hematuria, and assessment of quality of life in the history is strong, recommended.
Then everyone describe and physical examination of the patient. Then what will be the data? Sandra, of the son. Can you describe the physical examination?
What is it?
The physical examination of a patient. What are the checkpoints you see that सकते हैं कि ये चीजें मैं देखना चाहूंगा एक पेशेंट में जो कि न्यूरोजेनिक ब्लैडर है.
So we'll definitely start with the general physical examination, and then we'll go to the abdominal and urological examination of the genitalia, specifically
Okay.
to see any swelling or tuft of hair or any sacral pit if we find that.
One thing. Yes. You examine the clothes. For example, if a patient is complaining of urinary incontinence, और वो catheterized नहीं है, so there is an objective evidence कि the clothes are wet or not. Then starting from the trouser, तो उसमें आपको पता चल जाएगा. सर उसमें और कोई ऐड करना चाहेगा फिजिकल एग्जामिनेशन में?
So specifically the physical examination related to the only the urogenital system. As the son said, we will when the patient is, we will see the dresses of the patient. His dress or trouser is wet or dry, and after that, when we the genitalia and the lower abdomen, we can see the hump in the lower abdominal area, which is maybe the finding of the bladder. And the patient might be leaking at that time also, and after that we will see the skin excoriation due to the continuous urinary leakage from the patient. And while seeing the back of the patient, we can see the any defect in the whole vertebral column, if there is in malpositioning or disassembly or the absence of coccygeal tip or sacral agenesis. We can find that these things on the palpation of the patient. And we can also assess the S2 and S3 nerve roots of the patient. We can also check after taking the इजाजत लेने के बाद हम पेशेंट का external urethral sphincter by doing the DRE, we can cast the patient to cuff, and his external sphincter we can check.
There is a role of DRE.
Yes.
Dr. Sadia, will you add any point?
So before adding that, just a quick tip. So to the residents sitting here, when you do your examination, just when you mentioning about the general physical examination, you do talk to the patient and you ask them, "Aap kaise hain? How are you?" You might be picking up some tips from there. You've mentioned a very good neurological examination, but usually we do not do that. So a very easy tip is when you talk to them, you can pick up so many pointers from them, from their facial asymmetry, from the way they are comprehending to what you're saying or not. The other important tip I've noticed is that when patients come to you, there are young people who are coming to you maybe on wheelchairs or crutches. Ask them why they are on wheelchair. You might be making a significant change in their lives. If you pick it up early, if they've come to you in a month's time or maybe a couple of months' time, you can make a significant change. We are all here to decrease the disability. Yours is a major aspect, and coming to me is the motor front. So if we can make them less disabled, that will make them, a better citizen of this country. We need able citizens. We don't need disability here. So ask them why you are on a wheelchair. That will give you a lot of answers. You can pick up spine injuries. You can pick up strokes, young strokes too. That can help you too. And very simple question, very simply, I've even taught this to the residents who are non-neurology residents. Talk to them, face is there. Ask them to lift their hands out like a pronated ref. Very easy. And the other thing is check their planters. So easy, simple. You don't need to be a neurology resident to pick it up. And then you can send the patient to us. The other thing that we see is that we get a lot of lumbar sacral MRIs in somebody who might be having lower limb weakness. When you do that, quick question, ask them, do you feel any numbness from waist down or anywhere else? You do that, then instead of ordering a lumbosacral spine MRI, go a level up. Ask the MRI people to cover the lower dorsal spine. That can help you easily and help us all, and we can easily come up to the diagnosis as well. And your question for DRE?
Yes.
Is there
any relationship between upper motor neuron and the lower motor neuron?
From the neurological aspect, to be honest, I might not be doing it, but I might be asking them questions, if they're lower limb weakness, and I ask them quickly, are they constipated, especially in early Parkinson's disease? You ask them, that gait and their mass phase, you ask them, were you constipated before that? And you might be noticing the gut-brain link. So they have constipation prior to their motor symptoms of Parkinson's being more vivid. Thank you.
And the other thing which is related to DRE, it might not be directly related to expertise of Dr. Sadia, but it is related to ours, and that is bulbocavernous reflex. Now, I'm surprised that nobody is, till this moment, nobody has told this thing. आप बताइए.
One is reflex, not DRE, but you have to put finger.
No, it is done during DRE because your finger is within the rectum, and then you will.
Infections, yes. So it has what?
बताइए.
Permanent reflux. You put your fingers after consent and counseling of the patients. You put a finger in the anal canal हो सकते हैं, and in case of males, you squeeze slightly squeeze the glands हो सकते हैं. So there is a contraction.
Can it be done in females?
Yes, it is definitely performed in females. You slightly squeeze the labia.
Like towards the pubic symptom. Then you get the contractions.
Contraction.
Yeah, that's why.
And what it signifies? For instance, if it is positive, if it is negative.
It basically signifies that the root value of the bulbocavernosus is the S2, S3, and S4. So they are intact.
सादिया बताएंगे. सादिया रूट वैल्यू बताएंगे.
तो हमारी जो किताबों में लगा हुआ S2, S3, S4 लगा हुआ bulbocavernosus की.
से थोड़ा ये आउट हो रही है बात. हाँ, क्योंकि उन्होंने मुझे बहुत सारी चीजें इन्होंने रिवाइज करा दी. I mean that DRE, I mean I picked it up from him so well. We usually do not do so, to be really honest. But I'll go back and read on it. Thank you.
Basically, it tells us about the integrity of the second level of spinal cord. And if there is any impairment in this reflex, we can also it's not confirmation, but हमारे दिमाग में एक point जरूर आ सकता है कि it's involving urinary system, the rectal system, as well as the sexual system of the patient. So we have to assess those systems as well, which obviously we don't have a time with. We usually deal with the bowel and bladder issues, but obviously we come to know in a very एक rough way में हमें idea हो जाता है estimate. Sacrospinal cord segment की integrity हम देखते हैं.
That's one down. That's one. This two is three.
आगे बढ़िए.
Diagnosis of different type of dysfunction will involve the detailed history, medical history, and proper examination with the bladder diary are mandatory. Early diagnosis and treatment are essential in both congenital and acquired neurological disorder to prevent the irreversible changes in the lower urinary tract. Early intervention can prevent irreversible deterioration of lower urinary tract symptoms and upper urinary tract. The bladder diary provides the data of the number of voids, voided volume, pad weight, incontinence, leakage, urgency episode. And 24-hour bladder diary for 3 consecutive days is reliable. This one is our institute bladder diary. Management of primary aim for the management of urological symptoms are the protection of the upper tract, achievement of continence.
Mahibullah, please. What are the basic workup regarding the neurogenic bladder? Starting from labs to imaging. Can anyone? Dr. Aga.
From labs of the neurogenic patient, we will get the baseline labs of complete blood count and renal function test and urine detailed report and culture sensitivity. And from the radiological point of view, we will do the ultrasound whole abdomen and full bladder and post-wide if the patient is voiding it is. Sir, in the patient with the neurogenic bladder and incontinence, there is another involvement of bowel in also, because the neurogenic bladder bowel we can see that the excessive bowel shadowing there in the abdominal cavity. This the baseline workup. And then after the urine DR and culture sensitivity, we will get the frequency and wide chart given to the patient to get the frequency and other about that. Along with that, and after that, we can spread.
No. So stop that. So regarding the initial workups, as you rightly said that the CBC, the urea creatinine electrolytes to rule out other pathologies. Third thing is the fasting sugars levels हो सकते हैं, fastings along with the random blood glucose levels. Then we go for urine DR and cultures. Then regarding the imagings, you rightly said that ultrasound, AUB, along with the pre-void and post-void, and the X-ray abdomen to rule out the the whole spines, along with the sacrum and the coccyx, and the fecal loading. And then we again move to the MRI. We usually performs the MRI lumbosacral spine. Before that, we go for X-ray lumbosacral spines, AP and lateral views. And
what is the advice? Should we go with numbers later, or then we go for MRI?
So, so I'm just wondering, we're giving a lot of radiation to fit the X-rays. So when you're talking about X-rays, you want to look at the bone. Would it be enough that the history is significant? And when you're already ordering the MRI, our hospital is the radiology system is really good. They already do the MRI and the X-rays at the same time. When you order a spine, they'll automatically cover the X-rays. So when you think about radiation, just, when you teach our residents, what are we going to be getting out of the specific investigations at every front? Yes, we are a center where everything is free, but we are round-triple. We all have to audit ourselves. So when answering a CBC, what are you looking at? The infection, at the anemia, at the platelet count, if there is a history of fever. Then you're looking at the creatinine. Yes, renal function. Why do you want to look at the electrolytes? Until unless there is so we tell our residents, that until unless drug history, the patient is on any kind of diuretics or they've given any history of nausea, vomiting, would it be significant? Then yes, urine DR telling us protein and the infection with the cultures. Moving on to the ultrasound, KUB, obviously will help guide us really well. X-rays, I've learned it. Thank you, Dr. Aghat, mentioning about the fecal loading and all. That's helpful. When we ordering the X-ray of the abdomen, that's not going to be looking at the spine at any front, right? Or will it cover somewhat? I'm just considering the radiation flow, bringing it down less for the patient. Right.
Follow the patient. Frequent X-ray abdomen. Mostly those patients who usually have a chronic constipation. So since it is cheap, it's easily and readily available, easy to assess. So in order to see the bowel status, we usually perform repeat X-rays, not to that frequent extent, obviously, because it carries a lot of radiation. But since we cannot repeat with the higher investigations times and again, so this is a reason that we usually follow in neurogenic patients who are having chronic constipation with the X-rays.
All right. Okay. Thank you. Thank you in explaining that. And MRI, of course, looking at the nerves. The cord is going to be above L1 and the bone, and what else should it be? The sacral agenesis, spina bifida and all. That'll again help you with the history. And if you see a patient not walking, ask them history and go a level above with the MRI, covering the lower dorsum.
We see different patients in clinic. Some are with spinal cord injuries, meningomyelocele. They are straightforward because we know neurological problem is there. But many patients are coming with lower tract symptoms, but they don't have evident neurological problem. And then we go for MRIs in those cases. So, yeah, sometimes we get
prolapse, sometimes we get some abnormalities in spines. But when we send these patients to you, the then opinion is that it has no concern with the bladder dysfunction. So in those cases, we are stuck up. We don't have diagnosis, but in urodynamics is abnormal. So these cases are difficult cases because we then cannot say that what is behind this, the symptoms of lower tract, and you assess the prostate in male patients, old age, and diabetes in females and males both, but still there is a problem in these cases. And how to then go with the, because sometimes we have to perform bigger surgeries like augmentations, but we are still confused that what is the cause behind these cases. If evident causes are not there, spinal cord injury, meningomyelocele, or multiple myelomas or sclerosis. Yes. So these cases are a little problematic for us.
You want me to tell me you how I do it?
What to do?
What to do?
How to diagnose?
So someone, when you send me, when Dr. Murli sends me a patient to assess to find out if there's any cause, because you guys help us on at the front when how can we improve the quality of life, and we help you on the front that what is the cause so that this cause is not repeated again. So when a patient like this comes to you, so what I was taught and I'm still want to teach to all of you: history, and history. Ask and ask again. What is the reason that brought this on? Was it spontaneous, sudden, gradual? So history makes a big difference. Then also ask about the family history too. Many of the time, many Parkinson patients are messed up. And they might be presenting at times to you with early Parkinson and to us too. The initial symptoms are just not picked up, and with time, those symptoms get realized that this could all be because of it. Now, with multiple sclerosis and neuromyelitis optica, spectrum of disorders, these are the most ones that we see, and we've been treating thanks to you. We picked up young girls and young boys too, and we've given them one of the best treatments for NMOSD disorder, which is monoclonal antibodies, and trying to improve their quality of life. So, after taking the history, most commonly is the vision, spinal symptoms, difficulty in walking, urinary symptoms too could be one of the initial presentation, and then young strokes. People younger than 40 having a sudden onset of unilateral weakness. Those are the common things that we see. Then on the lower motor neuron disorder, then could be myotonias and dystonias and all those. So after taking the history, drug history, very important on that front. Any RTA histories, any spine history, there's past medical history. And then quickly going on to the neurological examination, vitals, always check the blood pressure. Make sure if one of your staff member is there who can help you out, check on the blood pressure. That is going to make your life very easy at times too. And put your hand on the pulse and just check the anemia. Simple things that you do, and talk to the patient. Check them if they smile well, their face is both sides are symmetrical or what. And then I do an examination. Of course, if I don't do it well, then I won't be able to pick up my lesion well. Because for a neurologist, it's important to localize the lesion, whether it's the brain and the pons, whether it's the upper motor, whether it's the upper cervical cord, the thorax, or the lower down lumbosacral. Or am I looking at the lower motor neuron? I'm looking at the muscle or the nerve or at the neuromuscular junction. So if I'm not able to do that, then I should go home and give up my place. So that's about it. Thank you.
So aim of treatment is the protection of the upper tract and the restoration of lower tract function and improvement of patient's life quality. In conservative management, we also always advise time dividing. The behavioral exercise to practice bladder control is generally done in combination with fluid intake diaries. Limit fluid intake at night, routine bladder emptying between every 4 to 6 hours. Limit caffeinated and carbonated beverage. Double voiding is also advised for many patients and del-
Kind of patient would be advised double voiding. You can ask the audience as well. The concept of double voiding.
Double voiding is basically after voiding, the patient again pass the urine, and within 5 minutes, this is double voiding. The patient who are unable to empty the bladder completely.
Like most of the young girls present to us, young boys present to us, we do conservative management. So we usually ask them to void, have a frequent voiding, time voiding, and double voiding. So there is no absolute indication to go for double voiding in every neurogenic patient. It's just a part of a diagnosis, and then we proceed.
Especially in those patients where we cannot find the cause and the USMs are good, prostate is not enlarged, and we used to send them that go and be again. When we see that they are emptying bladder at second void, then we advise them. Otherwise, no.
Otherwise, not.
Because if there will be residual urine, then there will be more STI than the restoration of upper tract. So patients where we cannot find a cause, for example, UFM is good, prostate is not enlarged, there is no neurogenic cause, which is treatable. So we then advise them that an upper tract is okay, normal. Then we advise them that go and we have confirmed that they are emptying their bladder in second void. If they are not emptying their bladders in second void, then we have to proceed for diagnosis, further investigation, and then treating those people. Maybe CAPCAN, CLCs, and they can measure.
Delayed voiding, if have overactive bladder, sometimes will start by delaying urination at few minutes and slowly increase time to a few hours. This help out to put
पेशाब रोके नहीं बस कर लिया इधर हम कह रहे हैं डिले करें voiding. तो अब
This is this basically when you're sorry, sir. There are two different pathologies. If a patient presented with frequency and urgency, and the durations and the objective evidence in the bladder diary says that KG patient void of every 15 or 30 minutes or less than 1 hour. So and with UDS पे भी उसको जो है वो ओवर एक्टिविटी मिल रही है, ओवर एक्टिव ब्लैडर मिल रहा है, along with the medications आप पेशेंट्स को साइकोलॉजिकली वो एडवाइस करते हैं कि फॉर अ टाइम बीइंग जब भी वॉइडिंग की एक डिजायर हो रही है यू हैव टू डिले दैट वॉइडिंग हो सकते हैं अगर 30 मिनट्स में आ रही है सो यू ग्रेजुअली बिल्ड अप दैट जो ड्यूरेशन है वो फ्रॉम 1 आवर 30 मिनट्स तक या 2 आवर्स तक एटलीस्ट जाए with the support of medications and this delay tactics जो है ना will improve the symptoms of the patient. सर डॉक्टर आदि साहब सर आप स्टार्ट करेंगे
आपने क्या कर दिया लेकिन एक पेशेंट जो OAV के साथ है ऑलरेडी प्रेजेंटेड विद अर्जेंसी एंड अर्ज इनकॉन्टिनेंस उस बेचारे को एक अच्छी खासी डिजायर है और वो वॉशरूम वैसे ही जाते जाते लीक कर जाता है आपने कहा डिले करो ये तो पेम्पर प्रोजेक्शन एक्टिविटी है
सर मैंने सर जब भी सर along with the medications है जो है ना antimuscarinic agents
रैशनल क्या है इसका व्हाट्स द रैशनल बिहाइंड दिस एडवाइस डबल वार्निंग का तो एक रैशनल है ना कि यू वांट टू मेक एन एम्प्टी ब्लैडर सो देयर इज नो स्टेसिस डिलेड refilling less chances of infection so what's the rationale of delayed voiding
sir delayed voiding is
for example prostate surgery में हम अर्ली कहते हैं क्योंकि जब कैथेटर निकलता है उसको frequent urination होती है तो हम कहते हैं कि होल्ड करो even you can hold manually so that there is some stress on your bladder and then with the passage of time you will be improved but what's the rationale behind delayed voiding in overactive bladder मुरली साहब ये तो हमें नहीं समझ में आ रहा है कहते तो सर हम बहुत
हाँ, मैंने कि मुझे खुद समझ में नहीं आता ये, क्योंकि हम एक तरफ तो कहते हैं ना कि भाई रोके नहीं, यूरिन कर लिया करें, दूसरी तरफ हम कहते हैं डिले करें। मेरे ख्याल में सॉर्ट ऑफ ब्लेडर ट्रेनिंग है कि अगर पेशेंट इज एबल टू होल्ड इट, आई डोंट नो, मुझे तो वाकई समझ में मुझे भी नहीं आ रहा। खैर इसमें लिखा हुआ है, आपने लिखा तो मैंने कहा पूछूं। ये कहाँ से पढ़ा हमने सर?
सर ये नॉट
किस किताब से?
ये उससे कोई रिसर्च उससे निकाला था मैंने।
अच्छा, मेरा रेफरेंस दिया। ऐसी जो चीजें हैं ना जो थोड़ी डिस्कशन वाली हैं, उसका रेफरेंस जरूर दें। तो क्या स्टडी हुई, क्या हो?
frequency with a documented small capacity bladder, you may advise a delay wording so that there is a stretching and all that thing. But for overactive bladder,
हाँ, थोड़ा इसमें देखना पड़ेगा कि मुझे वाकई खुद भी समझ में नहीं आया, क्योंकि हम ओपीडीज में नहीं कहते मरीजों को, ये तो कहते हैं कि कर लिया करो, रोका नहीं करो, मगर ये हम नहीं कहते कि डिले क्यों करो। हो सकता है ब्लेडर ट्रेनिंग का कोई पार्ट हो, मगर इसको हमें देखना चाहिए कि स्टडी हुई है, क्या हुआ है।
सर ये जो चीज है ना सर, इट्स अ पार्ट ऑफ ब्लैडर ट्रेनिंग हो सकता है।
मैं भी
ये बट डॉक्यूमेंटेड प्रूफ अलोंग विद वही जो मैंने बात की थी कि ब्लैडर डायरी अलोंग विद सपोर्टिव एविडेंस टू
यस
यस
हाँ,
ये जी
मगर इस चीज को हमें देखना चाहिए।
प्रेशर्स बढ़ है।
टाइम हो गया वैसे, कितने स्लाइड हैं सर? और
सर ये जो पीड्स में हम हाइड्रो डिस्टेंशन करते हैं, थॉमस लाइन 3 to 400 रोकते हैं और फिर वो जाके यूरिन पास करते हैं, बच्चों में ज्यादातर हम पीड्स में करते हैं।
हाँ, वो तो हाइड्रो डिस्टेंशन का तो है, एक मेंशन है, और उन केसेस में हम करते हैं जो रीनल फेलियर वाले हैं ना, जिसमें हम समझते हैं कि बिकॉज ऑफ दे आर नॉट urinating for years, maybe 2 years, 3 years, they are on dialysis. So we feel that we should train these bladders by over distended them with the fluids, and then we see capacity is increasing or not. Because we do not find causes in these cases, neurological causes. Sometimes we also keep our patients on these hydrotensions in adults as well. We have one patient where we cannot find a cause of small capacity, and on cystoscopy, bladder mucosa is good, but only capacity is 150 cc 200. So we have kept him on hydrotension. Maybe capacity is increased and we go for transplant without performing augmentation. So we do in these cases, yes.
Is this not same thing?
I don't know. Delayed widening, we must see any evidence or any study on it, or maybe.
The pelvic floor exercise is important, which will help relax the bladder muscles. When you start squeezing, increase the strength of the sphincter muscles. External appliance we use peniculum mostly used, which is contraindicated. Condom catheter is using mostly, and drug management, a single with therapeutics, antimuscarinics is the first line choice of treating in neurologic detracellulose activity. Oxybutynin, trypsin, and tolterodine is also established effective and well tolerated. We also give the beta-3 like mirabigon, and we also use the alpha blocker temsulin, suliricin, which may be effective in decreasing bladder outlet resistance and post-work residual. These are the antimuscarinic therapies. The first line medical treatment is strong recommended, and alpha blocker to decrease bladder outlet resistance is also strong recommended. Catheterizations who cannot empty their bladder, we mostly use the patient to catheterize, or mostly patient with the CIC. We use mostly 12 to 16 FR in adults, and bladder volume catheter should not be exceed to 400 to 500 ml. So intermediate catheterization is a strong recommended by UA, and use of the sterile is catheterization also strong recommended.
लास्ट वाली लाइन जरा रोक रोक के जोर से पढ़ दीजिएगा पीछे वाले सो रहे होते हैं उनको पता नहीं चलता क्या लिखा है ना ना
अच्छा इस वाले
आफ्टर वाली
अच्छा
मैं पढ़ देता हूँ avoid enduring transurethral and suprapubic catheterization whenever possible तो प्लीज 500 सीसी ब्लडर में यूरिन होने का मतलब बिल्कुल नहीं होता है कि ईआर में उसको कैथेटराइज कर दें और जेनुरिन लिख के घर भेज दें देयर मस्ट बी सम इंडिकेशन फॉर दैट हर मरीज को कैथेटराइज नहीं करना चाहिए ऑलवेज ट्राई टू अवॉइड कैथेटराइजेशन
This is the surgical management we will further discuss on our next session. Thank you.
Thank you.